Good afternoon, everyone. Thank you everyone for joining. I'm Jim Kim. I'm the founder of Med School Mentor, and it's really great to have all of you here with us this afternoon. Today, we're joined by Dr. Frederick Lang, who is the professor and chair of neurosurgery at the MD Anderson Cancer Center. And for my Med School Mentor team, we have Matthews, Annalisa, Akshay, and Camila joining us as a panelist. And a brief highlight of our webinar series, we earlier this May, we had the privilege of hosting of the book for Dr. Lin. And starting from there, more recently, we hosted Dr. Lawton, Dr. Dunn, Dr. Kioka, and we are really happy and honored to continue that tradition with Dr. Lang here today. Dr. Lang here, as said earlier, is professor of neurosurgery and is the chairman of neurosurgery at the MD Anderson Cancer Center. He is a world-renowned neurosurgeon and a scientist whose work has really advanced the field of brain tumor therapy. He completed his medical training at Yale, residency at NYU, and fellowship in neurosurgical oncology at MD Anderson, where now he leads one of the most impactful brain tumor programs in the world. His research focuses on gene, viral, cellular therapies for brain tumors, and currently leads the NIH-funded SPORE in brain cancer program. As a prolific scientist, he has authored numerous peer-reviewed publications and led multiple clinical trials aimed at transforming the treatment of brain tumors. Dr. Lang has also served in significant leadership roles, such as the president of the Society of Neuro-Oncology, chair of the AANS CNS Section on Tumors, and holds editorial positions in neurosurgery, neuro-oncology, translational oncology. And today, it's such an honor to have you here today, Dr. Lang. And
thank you very much. Really appreciate the invitation, and I look forward to the conversation.
I believe Akshay had the first question for us.
Awesome. Thank you so much for being with us, Dr. Lang. I wanted to ask you a question. If you could take us back in time and kind of give us a glimpse and what led you to choose neurosurgery. And what was that thought process like back in the day?
Yeah, that's a good question. I guess some people, like when they're really little, they say, oh, I always wanted to be a neurosurgeon. I actually had no idea what neurosurgery was when I was younger. I came from, no one in my family was a doctor or anything, so I didn't know about medicine, and I was always interested in being a doctor because it seemed like a good job. You could help people. So with that in mind, when I went to college, I was really thinking of becoming a physician. So I did the usual pre-med classes. And in college, I took a course in neuroscience, the introduction to neuroscience. And we read Kandel and Schwartz was the basic textbook. I don't know if they still use that book, but it's an amazing textbook of all of neuroscience. And that really got me interested in the brain and how we function. And the thing that interested me the most was about how the brain mediates our emotions, our feelings. You know, you always know that the brain makes you move and stuff like that, but the idea that the brain is this organ that takes care of all of these things that we kind of think of outside of our bodies, or might be the realm of philosophy and things like that, is all part of what the brain does. So that really got me interested in the brain. And then during undergraduate, I actually worked in the laboratory of Bob Roth, who was there. That was just when the idea of the serotonin and dopamine hypotheses of schizophrenia and all of those were starting to come out. So I did some research in that area, and that really further, spurred me to want to study the brain. So then as I was thinking about research versus becoming a physician, I thought, you know, I wanted to be able to interact with people and you know, become what I was learning about it being a physician scientist. So I actually, when I was at Yale Medical School, I did work on the functions of emotional sounds that are produced by our brains, like you know, laughing, crying, and all of those, and how we make those and produce those sounds. And so as I was in medical school, I actually went into medical school thinking, well, I really like the brain and emotion. Maybe I'll be a psychiatrist. But then when I rotated through psychiatry, I didn't like it. I just didn't like it. It didn't seem like I was going to have a big enough impact. And when I was actually thinking of doing internal medicine because I went to Yale Medical School, and the internists were the smart people. They knew everything. They were the intellectuals. The surgeons were, not so much. But when I did neurosurgery, Frank Spencer was the chair of neurosurgery, and I don't know, it just caught my fancy, and I became interested in it, mainly because I felt you could have like immediate impact, and it was really important. You know, what you were doing was important, that people really needed you, et cetera. So then I applied to residency. Interestingly, I now do mostly brain tumors. And when I started, I was thinking more of things like functional neurosurgery, but it actually wasn't really a field where I was a resident. At NYU, we weren't doing any functional neurosurgery, and we didn't have any stimulators and stuff like that. And I was actually in my research year trying to do a project on spinal cord, recording electrical circuits in the spinal cord. And the project was going terribly. I wasn't getting any data. The surgeons weren't cooperating enough with what we needed. So in the middle of my research year, I went to one of my advisors, Max Kozlow, and he said, well, you know, there's this lady, Elizabeth Newcomb, and she's studying a new gene called the p53 gene in tumors, and you might be interested in looking at that. So I completely shifted my work and started studying p53 gene in brain tumors. And we wrote a paper on the p53 gene in brain tumors. And as most of you probably know, p53 gene is like one of the most known and studied tumor suppressor genes. And so that actually got me my career going, or my interest in brain tumors. And then I also realized that at that time that you could really be a physician scientist if you studied brain tumors. And when I was at that stage, there was actually very few people who thought it was valuable to become a brain tumor neurosurgeon. Everyone was like, yeah, everyone can take out brain tumors. What's the big deal? You know, it's if you can clip an aneurysm, then you're really a great neurosurgeon. So it's been interesting to see how the field has evolved. Now we have fellowships in neurosurgical oncology, you know, and lots of research, and lots of people are interested in brain tumors. So that's it in a nutshell. My whole life.
Wow, thank you so much. Now, another question for you.
So
If
if I
you
could interrupt for 1 second, I have a saying in my life. God gets you where you should be, not where you think you ought to be. And I think that's sort of things that happened along the way. I always find interesting, because like, I don't know if I would have chosen all of those things, but opportunities came, I took them. So I feel in some ways that there was someone guiding me along, getting me where I should be, rather than where I thought I ought to be, which is something maybe people keep in mind as they're going through their career, and opportunities arise, and how you make choices. So something to think about.
Oh, that's deep. Thank you. Uh, Now, if you could give us a little glimpse in your day, like for
Oh my
our
God.
audience, if you could walk us through maybe an OR day and maybe a
Yeah.
clinic day, how do you go about it, and what are specific aspects of the day?
Yeah, that's an interesting question. So I have very different days. It used to be more, ever since I became chair, I've had a lot more meetings in my days, right? Meeting with people, meeting with other department heads. So like today's a good example. I came in the morning and we have what's called the community of chairs. And I'm on the executive committee of the community of chairs. So all the chairs get together and, you know, interact with, today we were meeting with the chief medical executive. So I was in at, 6:30. That meeting started at 7, led that meeting for an hour. And then I had to run up to my office to meet with this group of people we've been collaborating with on a project around a gene called TREM2, and we were doing work for them on an antibody. So I met with them for about 45 minutes to an hour. And then I had to jump back to my clinic, and I went down there because I had to see a patient on an off clinic day. I don't have clinic today, but I'm trying to enroll them in one of our clinical trials. And because of the way the time slots worked out, so I ran down to the clinic, met them for an hour, talked to them about the clinical trial. It turned out they decided to enroll in the trial, so that was very exciting. And then after that, I had to come back and meet with the head of imaging, our radiology department. And now I'm on this. So that's sort of a common day for me, mixing administrative things, right, as the chair, with patient care and with science, doing science. So some of the days, when you say about the OR, I love the OR because I can just put everything aside and I have to focus on one thing. To me, when you go into the operating room, that you can't have any distractions. You have to be focused. So I love going to the OR because my beeper goes over there, my phone goes away, and we just focus on the patient and taking care of the patient. And most of my cases now are relatively complex brain tumors like insula tumors and things like that. I'd say 80% of them or more are awake craniotomies where we're mapping the brain. So that would be an ORD. The other day I like is Friday, because on Friday, that's a little bit of more of my research lab day. I meet with my lab for 2 hours and we go over projects and people present their data. So that's a lot of fun. So I've always felt blessed to have all 3 of those kind of roles, which gives me, as the chair, I get a great opportunity to interact with all the faculty, all the fellows, residents, et cetera. So, and then I have the research and the clinical things. So it's usually a full day. I usually get up at about 5 o'clock, 4:45. I usually get home about 7:30, something like that. And then like today, I'm going to go work out at the gym. I decided I needed to make sure I have someone there. So I meet a trainer there and I go work out, and I try to do that 2 or 3 times a week. So I don't get too overweight as I do all these other things.
Awesome.
Nice. It's very different from what I've experienced here with neurosurgeons. Here, it's more focused on surgery only and clinical days. Your routine looks very mixed, and this is kind of nice.
Yeah, it is
So
nice. Yeah, so on today's Thursday, like Wednesday, yesterday, I was in clinic from 8 o'clock till 4:30, and then we had tumor board. So that's another day where, mostly clinical focus. So every day is a little unique, but very, very, very diverse.
So for the next question, Dr. Lang, I'm going to change subjects. Your contributions to the field of research are outstanding, and many IMGs dream of matching into residency, and we know that research plays a major role in the match process, especially in neurosurgery.
Yeah.
And I want to ask you for advice. What advice would you give to IMGs who don't have access to research opportunities in their home countries, but want to compete for a paid research fellowship position in the US because it can be very difficult for them to afford living in the US without a salary.
Yeah. Wow, that's a tough question because you know, I think international medical graduates trying to get a neurosurgery position in the United States is not easy. And it takes a lot more fortitude and grit than if you're, if you go to medical school in the United States. I do think there's value though to trying to do some research in the United States if you're interested in doing that. Now you can improve your chances of getting into a residency in the United States if you try to write some papers in the program that you're in the country that you're in. And the thing about that is I think that shows your interest sort of in the academic side of neurosurgery. And you're absolutely right. Increasingly, the competition with people is, I'm amazed. Some of the applicants will have, 20, 30 papers. Now there is a bit of a paper mill sometimes inside the United States where people able to churn out papers and they don't necessarily actually contribute to them. So what I like to tell people is I think it's best to do some kind, if you don't have access to a research lab, do some kind of retrospective review, meta-analysis, something like that. But do it. You be the person leading it so that when the paper comes out and people ask you about it, you know what you're talking about. And to me, I am always more impressed by an applicant who's had 3, 4, 5 papers, but every time I ask them about the paper, they know exactly what the results were. They know how much effort they had to put in it, rather than someone with 20 papers. And I ask them, what about this paper? Oh, well, I don't really know. That to me, that's not as impressive. Okay, so the idea of doing research, though, I think that actually not only improves your chances, because I don't necessarily think it's worthwhile to do anything just for the purpose of, getting into a residency or something. I think you have to have a little bit of a passion for it and you actually want to do it. Having said that, I think it is a valuable learning experience to work in a laboratory and to learn about the scientific method, about setting up experiments, and then you learn how to read the literature. It also teaches you how to think, right? How to troubleshoot, how to solve problems. All of these skills are necessary for a neurosurgeon. In addition, like if you come to my lab, we do carotid dissections and we inject things in the carotid artery. And on a mouse, that's not the easiest surgery. So you do get some surgical skill. You have to do it under the microscope, little things like that. So the question, though, you're asking me is how do you get that in the United States? And I think it's a little bit of luck and perseverance. So my mentor, Dr. Sawaya, came from Syria, and he tells the story how he wrote. Now, back then, they didn't have email, so he had to type it all out. He wrote 300 letters to people in the United States, and he got nothing back, zero, zero back. So I think you have to be ready to take the rejection. In this era, it's easier to email people. But I think you should, put your resume on there, put your interest. I don't know if you can do it without it. If the place you come from has grants or something that allows you to travel and go there, that's a good sign. But I don't think you can do it without getting a paid position. But there's many places in the United States that allow you to come and have a paid position. And, I get solicited all the time. I don't have many places in my lab, but I've had several Japanese people come over. Now they tend to want to go back to Japan and do residencies in Japan because it's good neurosurgery there. But I think it can be tough. But if you get an opportunity, no matter where it is, take it, right? Because you might not get another one. And once you've got an opportunity and can show that you're good, you can often jump to another one. I think it's going to take more than one before you would become necessarily get into a residency easily from a foreign,
Mhm.
you know, from an international medical graduate. But my only advice would be persevere, and if you're passionate about it, it'll eventually work. But it's not gonna. It's don't take the rejection personally. Just keep trying.
Thanks, sir.
Thank you so much. So we have a question from the audience. Mohammed, you can open your mic and ask the question directly.
Hi, dear professor. I'm a medical doctor from Iran, and I
Oh.
have more than 30 published papers. Mostly of them are related to spine, orthopedic surgery, and neurosurgery. With this situation that President Trump had issued these situations, is there any possibility to go into some research position and after that go to the residency? Thank you very much.
Yeah. You know, similar to what I was saying, I'd say absolutely. You know, you're in a good position. You're already, you said you're a neurosurgeon, right? So you already have worked in neurosurgery, and then you have a good
No,
amount of
excuse me, dear professor. I'm a medical doctor. I don't go to the neurosurgery residency in Iran, but I want to do a neurosurgery residency in the United States.
I see. Yeah. So still you have a little bit of an advantage, right? Because you're already a medical doctor. But I think you're going to have to, it would be valuable to try to get a research position, or you're going to have to do something in neurosurgery, right? So it might be that can you do some kind of training in neurosurgery in Iran, or do some, types of work in Iran as a starting point, and then come to the US. That might be an avenue. But I would just, I get a lot of requests from all over the world. Iran seems to be an increasingly common place for people to want to come to the United States. But again, I would say there is opportunity. You're just going to have to keep looking and applying. I don't know if there's any. So one way to do it is like look at different institutions and who's doing things you might be interested in, who has laboratories, and just reach out to them and see if they're willing to take you. There's a lot of things posted. For example, at MD Anderson, we have all sorts of job listings posted, and you can always look on there and see. But it's very competitive.
Thank you, Dr. Lang. So through your career, you have combined your passion for research with a strong commitment to medical research. How has your work in research shaped the way you approach patient care, whether in how you make decisions, weigh risks, or communicate with your patients?
Oh, that's a great question. So I've always thought, I've always valued the idea of the physician scientist. And that was one of my goals when I was younger, to be a physician scientist. So to me, the one of the most impactful things one could do would be to change the way we treat a disease or something, and that usually comes out of the research that you're doing. So in brain tumors, this has dramatically, affected the way I approach patients, because the goal of my laboratory has been to bring new therapies from the lab to the clinic. And we did that with a virus, an oncolytic virus, which I didn't do the whole work, obviously, but one of my collaborators engineered the virus, and then I did the animal work, and then we brought that to a clinical trial. And that's very exciting, because now you can offer something to a patient that up to that point is not available. And as I said, just this morning, I actually met a patient because we're trying to get them on our clinical trial. They're interested in doing something different because their tumor has recurred and they don't have very many options. So I think I don't know if it's changed my approach to the patient. I believe as a physician, you're there to help people, and get them through tough times, et cetera. But it has provided more opportunities for the patients because of the research we're doing. And I really think, you know, clinical trials are critical to what we do as physicians, especially if you're in an academic center. We really need to do clinical trials where we compare things and make sure we're doing the science well, and understand the biology. And as a neurosurgeon, I've been a big supporter of what I originally called biological endpoint trials, where we would give a drug and then take the tumor out and see what the drug or the agent does. Now they call them window of opportunity trials, where we use surgery as a window into the therapeutic. And in fact, that's the trial we're doing with the patient I enrolled. We have a window of opportunity arm where we're giving the virus, we're actually injecting the virus intra-arterially, and we're using stem cells as a delivery vehicle. And then we take the tumor out and see if the virus is there, et cetera, see if we're achieving our goal. So, yeah, so research and clinical care to me, like, are so closely intermeshed, and it makes the job more interesting, because you're always trying to think of something new from the physician side, and then it gives a lot more opportunities to patients to have, you know, different approaches which might not have been available otherwise. So that's been one of the most fun parts of being a physician, being able to do the clinical trials.
Thank you so much, Dr. Lang. Given also what you said previously about your day and your commitments, I wanted to ask you, given your experience collaborating across academia, biotech, and clinical environments, what's your advice for making such systems work together without compromising scientific integrity or speed?
Wow, that's a big question. So I think collaboration is important, and the extent of the collaboration depends upon you. So like, I have a very strong collaboration with one of the scientists here, Juan Foyo, and we've worked together, and we just work well together, right? We think similarly, we hold each other accountable, and we can have conversations, frank conversations about what, you know, what's good, what's bad. And I think that's important. So having local, internal, or close people to collaborate inside your institution, I think is very, very valuable. When you want to expand that out, and I think this is the essence of your question, when you want to expand that out to collaboration outside your institution, or even to different departments inside your institution, then it becomes a little bit more difficult. But I think as long as you're aligned and you set up, you know, careful goals, et cetera, what you're going to do, what the other person's going to do, I do think it's a lot harder. But for example, when we're doing clinical trials, we certainly need other centers to participate in order to enroll patients, depending upon the size of the trial. So I think all of that collaboration and that interactions with other academic people and centers is really critical to the growth of any field. I think it's especially important in sort of neuro-oncology, where we're dealing with relatively rare diseases. You know, there's really only like 15,000 new glioblastomas a year in the United States, which is not that many compared to like breast cancer and lung cancer and things. Thank God that there's not more, but it also makes, you know, doing these clinical trials a little harder, and you do need to expand out to other places. I think you mentioned industry in your question, and I think that becomes an interesting bargain with the devil a little bit, because industry, without industry, we can't succeed. We'll never get drugs to where they need to be. But I do think that the goals of industry, or at least the goals of sort of these startups and the business people who get involved, are a little bit different from the goals of many of us who are doing the research. So our goal is to try to develop something that will cure, you know, glioblastoma. I'm not really interested in making a profit off of it. But if you're in a business and you're in industry, you want to make a profit. And the problem can be that the decisions you're making are profit driven and not necessarily in order to achieve the cure goal. And that's manifests itself in many different ways. Like, are you going to do trial A or trial B? Are you going to just push something because it's at a certain stage? Or are you going to actually try to improve it before you do this thing that might get you a lot of money? So I've seen in brain tumors, a lot of companies fail because they aren't necessarily taking a logical scientific strategy. They're taking a business strategy. Like, our investors need to see the phase 3 trial. And if we don't do that now, we're not going to be able to get any more investors. And then the phase 3 trial fails and they don't get any more investors anyway, because they're broke, right? They go bankrupt. And to me, what we should be doing is, especially for things like brain tumors, doing small trials that allow us to figure out who the population of people is for which the drug or whatever strategy is going to work better or work the best, and then do the trials on those people. And we typically don't do that right now. So I think that, and I've been now involved with a company with our virus, and it's been an interesting journey. And so I think that as a person who, might invent or make a new drug or a new agent or a new strategy, the time to bring in the industry is sort of near the end, when you're ready to give the whole thing up and you pretty much are sure of the science, and now you just need somebody to get enough money to test it in the big trial. If you're not ready to do that and you think the company's going to work with you to solve scientific problems, maybe in the beginning it will, but at some point it will diverge from your actual goal. So my experience has been, be cautious when you start working with industry or business people. Eventually you need to do it, but the goals might not be totally aligned. So, or the other way it could work is if you quit your job as a doctor and become the head of the company and then drive the whole thing yourself. But that's a very risky undertaking. So unless you're a born millionaire, you probably might not want to take that route.
Thank you so much.
Thank you, Dr. Lang. I want to ask you if you have any ritual or a habit that you like to go about before your high stress days, or maybe whenever you're having a long day. So just wanted to ask you about that, and if you have any advice for medical students or residents on how to deal with those things and how to stay calm and keep.
So I actually am a fairly religious person. So I'm a Catholic. So I actually, in many ways, rely on my faith when it comes to these difficult things. Especially when you're dealing with people with brain tumors. Most of them, you meet them and they're not going to be alive in a year or 2 years. And that can be tough. So I usually, when I am driving to work, I'm usually praying. And when I get to work, I stop before I get out of my car and I say a series of prayers: Our Father, Hail Mary, the Creed, things like that. There's a Saint Faustina who has the Divine Mercy. And I think mercy is an important quality, value, let's say. Having mercy on other people, but also on yourself, right? You're going to make mistakes through the day, and you just got to sometimes forgive yourself and have a little mercy on yourself. So I like to stop and pray at the beginning of my day, and try to remember those prayers during the day when things get a little tough. Just take a breath and say, okay, say a Hail Mary or something. I know that's not popular anymore in the world, where everyone's becoming less and less religious, but I still think that's very valuable. That's been very valuable to me. I went to a high school called Regis High School, which is a Jesuit high school in New York City. Everyone there gets a scholarship. And that had a big influence on me in terms of my teachers. Many of them were priests, but they taught the value of being a person, a man for others, we called it, and how important it is to devote yourself to helping other people. And to do that, I use the strength of God to be behind me and to watch over me. And actually, before every operation I do, I actually pray before I operate for the patient, for the people in the OR, and that things turn out well. So yeah, that's what I do.
Thank you.
Yeah, thank you, Dr. Lang. Now, talking about mentorship, before becoming a mentor yourself, you were once a mentee. Who were the mentors that had the biggest impact on your career, and what was it about their guidance that stayed with you the most?
Yeah, that's a great question. Increasingly, there's this talk about mentorship. When I was going through it, I don't think anyone used the word mentor, and that you were a mentor or a mentee. It wasn't like a popular thing. So I do think, though, it's very important. Now, even though I don't think we had, like, when I went through college, medical school, we had like advisors and stuff, but no one really talked about, find yourself a mentor. But I think actually that's what happened through my career. So I just mentioned my high school, right? There were many people who through each grade of high school who, I was able to go to, talk to, get advice. I actually played basketball. And so things like your basketball coach really can have a profound impact on you and how you behave and what you value, right? When I was in medical school, there was the person who I was working with in the lab became a very strong mentor, and encouraged me to become a physician scientist. And sometimes a mentor is just a person who listens to you. It doesn't have to necessarily give you the greatest. They just sort of say things like, "Well, what do you think you should do?" Or "I think you can do it, so go ahead and try." Right. Many of the surgeons I had when I was a resident were incredible mentors. There was a guy, and they're often not the best known people. There was a guy, Max Koslow, who was so I worked at Bellevue Hospital, which is a city hospital, and Max was oversaw the residents at Bellevue Hospital. So he was the guy with Bellevue was where you got to do a lot of things on your own. And Max was the guy who was willing enough to let you do it on your own and not take the case away from you and watch you and guide you, et cetera, but also help you make decisions and things like that. So he was an incredible mentor in terms of my neurosurgical career and things like that. When I became an attending, my early career, Ray Sawaya was a great mentor. He really took me under his wing. NYU was quite a rough program, and he was much more of a kind and gentle person, and that really had a lot of influence on me. But one of the interesting things, I had a mentor. I didn't call him a mentor, but when I first started my laboratory, I really didn't know how to run a lab and all of those things, how to get a grant. And there was a guy, Phil Toffelon, who was a PhD scientist. And to this day, I never knew why. He kind of took me under his wing. He taught me how to run my lab. He helped me write my first grant and get my first R01. And there was no benefit to him. We kind of got along, but yeah, he was an amazing help, and in that way became a mentor about those kind of things. So yeah, I think I've been blessed. I've met many people throughout my life, who my mom and my dad, right? I mean, when you stop and think about all the people who you run into, my colleagues, even now, even though I'm the chair, actually the faculty teach me a lot about things that, how to do things. And I think if you have another important quality, which is humility, things can, you're willing to listen. I think that can help you a lot going through life. Humility is an interesting thing now. I think the world is increasingly becoming less and less humble between Instagram and Twitter. Everyone's out there bragging about everything they do. And I think maybe it would be good if we just dialed that back a little and stop having to, just because you ate a nice looking, banana bread doesn't mean you have to post it. It's like, so I think a little humility might be important to inject in our society at this point. That might not
Thank
be a
you.
popular view.
No, it can be a popular view. Thank you for sharing your experience. And now, as a mentor yourself, are there any values or habits you try to pass on to your mentees that you maybe feel that are essential but not often emphasized enough in medical school?
You said habits?
Yeah, maybe habits or values.
Yeah, values. Yeah. So I just told you one of them, which is humility. I think also,
Yeah.
I mean, to me, values are all the most important thing. And probably one of the most important is honesty, right? And it's a little distressing to me to see a lot of the science, like papers being retracted because of scientific fraud. You have to, that breaks the whole trust in science, and we have to be really careful about that. So I think that's important. I would say one of the most important things, especially about neurosurgery, is trying to make yourself better every day and better than you were yesterday. And neurosurgery is not an easy thing to do. And I've been doing it for 30 years and I'm still perfecting the skill. And I think you have to maintain that sort of outlook that you can always be better, and that you learn from what you're doing today will teach you for something tomorrow, but you should always be trying to improve yourself. And be honest with yourself about where you are, right? So if you're, especially when people first go out into practice, like if you're not ready to do something, like you shouldn't do it, right? Which is not to say that you can't, incrementally do things that are more and more difficult. But it's great to have like a backup system inside your program or wherever you're working who can work with you and get better. But I think it's a lifelong devotion to improving yourself. I guess people say, lifelong learners. And that means you keep up on the literature, you keep up on the techniques, you go to even now I will go to the cadaver lab and do dissections so that I can get better at what I'm doing and understand the anatomy better and the positioning and all of those things. So I think as a physician, that's an important quality. And I think that starts in medical school, in college, when you got to devote yourself to studying. It's not easy. It's a lot harder to sit down and study organic chemistry than it is to go drink the organic chemistry. But I think those kind of habits are important. So you say habit, and what comes to my mind is the idea of discipline, right? Being willing to do the harder thing, even though it might be less fun, but that's what's going to get you where you're going to be. And in the long run, I think devoting yourself to some of these things that are harder, in the long run pays off. And so like when you're in the early stages in grammar school, high school, medical school, what you're doing when you have that kind of discipline is you're investing in yourself. You're investing in your own success. And I think that's important, you know, to recognize that you can be successful, but it's not going to be given to you. Yeah, you have to work, right? The only place where success comes before work is in the dictionary. So you really have to, you know, you have to put in the time if you want to be successful. I think if you talk to athletes, you know, like you talk to people like Michael Jordan and stuff like that, not that I've ever talked to, but I think what they recognize is that they're very talented, but there's a lot of other talented people too. And what takes those elite people over the top is their work ethic. So like they're in the gym first and they're out of the gym last, right? They're exercising, they're putting up more jump shots, say, and practicing, or if you're a soccer player or a football player, you know, you're kicking the ball in the goal many more times than the other guy, you know. So I think that's key. You got to keep pushing yourself and have discipline and keep educating yourself.
Thank you. Excellent insights. Thank you so much. So if anyone wants to ask a question, please raise your hand. Right now we have one from Oviora. You can go ahead and ask your question right now. Or
Is that the thing in the chat? I'm seeing a question in it. It says from Ibiora Okoya.
yes.
Oh, here he is. Is he on?
Yeah, I think he is.
Do you hear him?
Okay, I can read it.
Okay.
So, Dr. Lang, your role as a chair encompasses clinical, research, and administrative responsibilities. Could you share how you prepare for the administrative aspects of your role? In your experience, is pursuing an advanced leadership degree, such as executive MBA, valuable or necessary for success in academic leadership?
Great question. So I do not have an MBA. And having said that, I always thought, well, maybe I should do that. I guess it depends how high up the executive or the administrative ladder you want to move, if that's really your passion or not. So I would say the training I had for being the chair was mostly by observing the people who I knew who were in those positions. I then did some reading and things like that, but I never actually took, well, I took a small leadership course halfway through my career. Interestingly, after I became chair, they actually have a leadership institute at MD Anderson, and I took 2 years of leadership courses that I was invited to take, which I thought were quite valuable. Also, interestingly, my wife, who's a physician also, took a sabbatical for our family. But during that year, she said, I'm going to get an MBA. So she got an MBA from the University of Michigan. And while she was taking her MBA courses, I was like listening to her and talking to her and reading some of her things. So I sort of got a glimpse into what an MBA can offer. So I would say that if you're interested in being a chair or having an administrative position in your hospital, you can do that without having an executive MBA. I think, though, that in this era, increasingly, if you want to move up to, say, being a dean or, you know, something like that, a little bit higher, the executive MBA is probably a helpful thing to have. It gives you a different perspective on leadership. You learn more about finance. You know, you learn other areas that we don't learn as physicians. And as with anything, the more you know, the better you're going to do at your job, right? And I think there is value in that. Do you absolutely have to have it? No. I think there are people who are good at leadership and can move through and are it comes a little more naturally. Is it valuable? I would say yes. It certainly can't hurt. It's not easy to do though. You have to be able to carve out the time, et cetera. And many of these executive MBA programs that are, good programs, require effort and time, and you can't just like sit in once a week on a class. So that's a great question. I think it's increasingly, probably, 20 years ago, you didn't need it, but medicine's increasingly becoming, let's say, corporate, right? Businesses, they're run more and more like businesses and less like academic organizations. So I think that's a valuable, could be a valuable thing to have.
Thank you.
So, Dr. Lang, I had a pleasure earlier this week to meet you during a Zoom meeting. And it really stuck with me something that you said, that the best doctors have support systems to help decompress from all of the suffering they witness. And neurosurgeons deal with a lot of horrible diseases. So I want to know, what kind of support system have you found more helpful personally and professionally?
Yeah, that's a great question, and I think it is important. Especially as I mentioned in the beginning, we in neurosurgical oncology, we're taking care of people with deadly diseases, right? So there's a lot of stress put on us. There's also, I just recently learned this idea of a second victim. I don't know if people have heard this terminology, but the second victim is often the person who's experiencing the issue. So like, say a neurosurgeon causes someone to have a hemiparesis or something because of the surgery they did, right? Obviously, the victim of that is the patient, if you use the word victim, right? Because they're suffering the problem. But the second victim is often the physician or the surgeon, because it comes back on them. They're worried about, they feel bad that they did it. It's not, and in neurosurgery, this can be, very devastating, right? And so in order to cope with that, there needs to be you can internalize it, and that can lead to a lot of problems for physicians. I think this idea of second victim is actually very high in surgeons in general, and probably neurosurgeons. It's something that's pretty much unrecognized, or not fully recognized. What's interesting is when they do research on this, when the surgeons go back and they try to talk to their families about this, the families really don't understand. The best people to help them through this are actually their colleagues. Now, because they would understand what they're going through. The trouble with this is that the last group of people that you want to admit that you caused a problem in a patient is your colleague, right? You don't necessarily, so it creates this very interesting dynamic. So I think what we as leaders in neurosurgery, especially if you're the head of a department, is to create an environment where people feel they can discuss these hard things with each other, not only to get better at doing the surgery, but also to relieve some of the sort of, let's say, guilt or sadness that goes along with some of the things that we have to do as neurosurgeons. I think neurosurgery is particularly hard. Like, even if you do a perfect surgery, sometimes, let's take the supplementary motor cortex. There's a supplementary motor syndrome, right? You take the tumor out, person is basically okay, and then they start getting weak. They're actually developing apraxia. That usually recovers, but during the time when that is happening, the stress on you that it might not get better and the patient's worried, and it's not easy. So even when you do the correct thing and the right thing, and the person can have a problem. You take out a spinal cord tumor, person often has proprioceptive problems for a period of time after the surgery. It's not easy, right? But you have to take the tumor out. So I think creating, one of my goals as a chair is to create this environment where we can sort of relieve the second victim feelings and worries. So I think your colleagues in the right environment can be an important support. Having said that, I do think that your family is equally important. They might not understand everything you're going through, but I think it's very important that physicians value and take care of their families as much as they take care of their patients. And my kids often, I think sometimes they get neglected because I have to go to the hospital or things like that. So I think it's important that we really take time out and be with our families and show your family that they're first and that they matter to you. I think this is very, very, very important. And that requires, I think, being able to be present when you're with your family or people who are not in medicine. I think very often, I know I do this a lot, I'm kind of with my family, but in the back of my mind, it's like, oh, I got surgery tomorrow and I got to, this is brewing in my head, so I'm not really paying attention. And I think to be present and people use words that get bantered around now a lot, but they're kind of true. The idea of being mindful of the situation you're in and make sure you're fully engaged in that situation, really matters to me as something that would be a goal. So I think it's very important that we all have take good care of our families, create friendships outside of work, very important. And then I think it's important to be an environment and to help create an environment at work where there's less antagonism and more, support of each other, particularly within the group you're working in. If you can get all those layers in your life, that's pretty amazing, and I think that gets back a little to what I said in the beginning, mercy, right? Having mercy on yourself, mercy on others. It's all part of life.
Great answer, Dr. Lang. Thank you.
Thank you, Dr. Lang. We want to be respectful of your time. This is the last question.
Okay.
So we wanted to ask you, everybody in medicine and throughout the world knows MD Anderson is famous for their cancer care and how they treat cancer patients. So we wanted to ask you, how do you cultivate that excellence in your team and as a part of MD Anderson? So if you could touch a little more on that.
That's a great question. So how do we cultivate excellence? So the first thing is I take a great amount of time picking people to join our team who want to be excellent and make that part of their priority. And you can see that from their history. You can see that from, talking to them. And so that's the first thing, having a group of people who make excellence a priority, right? And being excellent means the things I just said, like continuing educating yourself, paying attention to details, making sure you're always getting better. The other aspect of this is let's call it accountability. We create an environment of excellence by holding ourselves accountable and holding our colleagues accountable. And that can be tough. But as a chair of the department, I really think one of my goals is to create an environment where everyone trusts each other enough that we can debate, come to conclusions, and then hold each other accountable, right? And I think that's important. And if you can create that kind of environment, right, where the expectations are high, so that's I guess another aspect of this, but you're going to hold each other accountable to that high expectation. And I got to say, we have some difficult conversations in our department about, when someone was on call and XYZ happened, For example, they didn't answer the call right away and it took a couple of hours, we hold each other accountable, right? What is the expectation of the group? We have a conversation around it, right? And then if you're not doing that, well, sometimes there's a reason, right? But that's a big thing. So I think excellence requires individual inner want to be excellent, and then in the group, setting expectations and then holding each other accountable to those expectations. And it becomes really powerful if the group agrees on those expectations. Like we all come to the conclusion, like this is what we want to do. We want to have 0 post-operative complications, right? That's our will we reach that? Maybe if we, but that's the goal, right? But that idea of expectation and accountability has to do with everything, like professionalism, another word that's thrown around a lot now in modern medicine, right? What does that mean? And how are we going to hold each other accountable to being professional, right? And I think that's important. MD Anderson, I think, is a unique place. What made me want to come here and stay here was when I walked the halls. First of all, they were all very clean and immaculate. And the thing that got me, though, was the people who were cleaning the floors were as much dedicated to the mission as the president. So if you asked the guy cleaning the floors, what's he doing? And he would tell you, I am curing cancer, right? And that idea permeates our institution. I think that's why we keep getting ranked as the #1 cancer center, because from the people who are doing the basic work all the way up to the president and the scientists and everybody is dedicated to that mission and sees that as an important thing. And they, as I said, they have high expectations of themselves. We have high expectations of each other, and we try to hold each other accountable. So that's the ideal situation. Yeah.
Dr. Lang, I want to deeply thank you for sharing your time with us. We are all deeply honored. We learned a lot with you. And I want to also thank the audience and remind them that all of our previous webinars are on our YouTube channel, and Dr. Lang webinar will be on YouTube as well. Dr. Lang, thank you again. It was a pleasure.
Thank you very much. I enjoyed the conversation. Thank you for insightful questions. I really appreciate it. And thank you for inviting me. I hope you enjoyed it.
Thank you, Dr. Lang.
Thank you, Dr. Lang.
Thank you. Thank you.
Take care.
Bye-bye.